ثالثة أو بدل، لأنه هذا من خارج الوطن وعلى برا الإنترنت وموعده محدد الساعة 12. فإحنا هنبدأ الآن بالسينيور كونسلتنت يورولوجي سانجاي كادجاي from Nepal in Fadia Hospital. Welcome, Dr. الآن على النت.
Yes.
Welcome, Dr. Sanjay, to my scientific conference and of Yemeni Urological Association. You can start your presentation.
Prof. Sanjay,
Yes.
can you hear me?
Yeah, I can hear you. Just a moment.
Welcome, Dr. Sanjay, to East Scientific Conference of Yemeni Urological Association. You can start your presentation.
Sure. Thank you very much. Just a moment. Can you hear me? Am I audible?
Yes, we can hear you. Please start your presentation.
There is some problem in my computer. Just a second. Okay. Can you see my screen?
Yes.
Yes. Please a minute, Doctor.
One minute.
Can you see me?
1 minute, Doctor.
Okay.
1 minute.
For me, it is seen. It is seen clearly for me. I don't know for the others.
غيرنا الجدول بس.
Am I audible?
Please a minute, Doctor, because we have a problem in the
Okay.
screen.
Take your time. Just let me know.
I don't know for the others. For me, the sound is clear and the slide is seen clearly. I don't know the others
Just
seeing it
on-
or not.
in screen in our hall. Not ready. Just a moment.
أنا أتكلم بس Dr. Sanjay.
Welcome to the second session presented by Dr. Sanjay Khadgy from Nepal, Senior Consultant of Urology. Welcome, Doctor, to the 8th Scientific Conference of Yemeni Urological Association. You can start now. It is all ready.
Okay. First of all, I would like to thank the Yemeni Urology Association for giving me this opportunity to talk on mini PCNL. Am I audible?
Thank you. Ready.
Am I audible to you?
Yes.
Good.
Yes.
So I don't have anything to disclose in this presentation. As we all know that mini PCNL is the modification of conventional PCNL with the use of miniaturized scope and a smaller tract less than 20 French, which was first performed by Halal in 1997 and developed by Zachman in 1998 using 11 French sheet in a pediatric population. Well, if you see the guidelines of AUA and EAU, there is no word like mini PCNL for recommendation. However, in recent years, this mini PCNL technique is evolving. In these last few years, there are more than 150 papers just on mini PCNL. As people are used to with the mini PCNL, they now aware of the advantages of mini PCNL technique. These are several papers just on mini PCNL technique. Well, I have been doing mini PCNL for last 16 years. Only about less than 1% we perform conventional PCNL. So this is a nomenclature of miniaturized PCNL. But the important is which one to select and why. In my regular practice, I have been doing this Chinese mini PCNL, which is about 14 to 20 French tract dilatation. In my own regular practice, my regular tract dilatation is 18 French. It's a simple instruments can be used for this mini PCNL technique. Whereas if you go with the ultra or micro or super mini PCNL, one must have laser settings and all. And it is important to know that why this 18 or 20 French Chinese mini PCNL. As we all know, and people are aware, if you perform mini PCNL technique, there is a high chance of renal pelvic pressure. But if you choose 18 or 20 French dilatation and 12 French mini nephroscope, there is a very less chance of raise in pelvic pressure. So that is why it is very important to choose the tract size and the scope. This is just to demonstrate you. This is an 18 French sheet and 12 French mini nephroscope. When you have a gap more than 4 FR in between the scope and the sheet, then you can have a smooth irrigation from the system, and there is a very less chance of raise in pelvic pressure, which gives rise to sepsis. So that is why it is very, very important. Next. So why mini PCNL? These are the simple instruments as you compare with the other modalities. 12 French mini nephroscope, whose working channel is 6.5. I prefer to use Zebra or Cobra guidewire of 0.35. My standard regular sheet is 18 French. First, initially, I make a dilatation with the 10 or 12 French, then immediately jump with the 18 French. This is a simple table. And anyone can start mini PCNL who have expertise on this technique. You don't need all different watts of laser surgery settings and all. So that's why I choose mini PCNL technique.
Can you start, sorry, doctor. Can you start your slide share?
Sorry?
Slide share.
Slide share? Oh, am I not sharing?
No.
Can you see this?
Slide show. Sharing.
We saw the slide. Here we saw it. I don't know what that.
Share screen.
عندنا شغاله عبر الزوم شغاله السلايد تمام. يمكن مشكله عندكم بالقاعه الله اعلم.
No.
منو اللي بيتكلم هذا؟
So you cannot see my slides, huh?
Now okay.
Just a second, I'll just change the settings. Can you see it?
Yes. No.
Yes.
Can you see this?
Yes, you can see.
Okay. So this was a paper by Derek. Mini PCNL for renal calculi. Does size matter? So even for the medium size stone, the stone clearance we can achieve is 95 to 100% with the mini PCNL technique. This is EAU guidelines on urolithiasis. Stone-free rates were comparable in miniaturized and standard PNL procedures. So there are different other techniques like ultra or micro PCNL. For that, there is a limitation of stone size, not more than 2 centimeters. However, one need to have laser settings for these techniques. So this is just a comparison of, this is my own paper published in Arab Journal of Urology, comparison of standard and mini PCNL for stack-on stones. If you see the stone-free rate, we can achieve even with the mini PCNL is 83% and 88% with the standard PCNL. So the efficacy of mini PCNL was comparable to standard PCNL in the treatment of stack-on stones. And this is a systematic review of almost 12,000 patients, shows the incidence of complication associated with conventional PCNLs. If you see the complication, that is about almost 20% in conventional PCNL. Whereas in mini PCNL technique, this is in the case of staghorn, in mini PCNL, overall complication rate is 8%, whereas 7% fall in Clavin window 1 and 2. If you see the complication in mini PCNL in staghorn is about 12%, as compared to conventional PCNL, you find 24.3%. Blood transfusion rate is about 2.4%. This is all in staghorn stones. So if you find in conventional PCNL, you can find 12.9%. That's too high. So one of the unique features in mini PCNL is the entry through the mid-calyx. In our regular practice, about 70% of our cases, we go through the middle calyx. When we go through the middle calyx, we can swing our telescope in upper pole and lower pole without much difficulty. Also, we can also advance to the upper part of the ureter. So we choose middle calyx, supracostal in most of the cases, about 70% of the cases. Why middle calyx? I'm going to demonstrate you here. So we perform mini PCNL under spinal anesthesia. Our puncture is between 11th and 12th, as you can see here. Why middle calyx? We try to achieve the angle. If you notice, the angle of puncture with the sagittal plane is less than 60 degrees. If you can maintain at the 30 degree, it's excellent. Our entry is just through the fornix of the calyx. So when we can achieve this angle, stone evacuation after the fragmentation is much faster with the gravity. Are you having my videos?
Yes, yes.
Okay. So why middle calyx? Again, I'm going to demonstrate you. If we achieve a lesser angle, you can, even with the flushing, you can evacuate the stone. It's a free flow with the gravity. But if you make a more vertical tract, stone evacuation is more difficult. These are the fragmented stones, just to demonstrate to you how easily these stones can be evacuated. So in our regular practice, what we use pneumatic lithoclass. It's a locally made. It's not a very expensive lithoclass. We use 1.4 mm lithoclass probe, as you can see here. We do not dust these stones. We make fragment of 3 to 4 mm of size so that these stones are accommodated in our sheet. And then procedure is very quick. Once these stones are fragmented into multiple small pieces, and you can have a picture like this. So intermittently removal of the telescope, which flushes out the fragmented stones. So what is the indication for mini PCNL? These are the list of indication. And in terms of stone size, there is no stone bar. There is no stone size. More than 10 mm stone, any size of stone can be removed with the mini PCNL. The only thing one should have a good expertise, and one should have a proper instrumentation. Let me share you some of the examples of this. This is a 1.5-year-old child who had a bilateral renal stone who underwent mini PCNL in our center. So we performed mini PCNL safely, and the procedure was uneventful, and it can be done safely. So mini PCNL also can be done in upper ureteric calculus, but for that we have to choose entry through the interpolar calyx. For example, here is a stone size of 6 centimeter. You need to have a middle calyx approach, only then you can get these stones. If you approach through the middle calyx, it may not be possible to remove all these stones. So mini PCNL has a high maneuverability, and you can have a high accessibility with the scope. As you can see here, we can achieve a complete clearance rate with the mini PCNL technique. Not only a small stone or medium-sized stone, as I already mentioned, that we can also perform in a complex renal stones. This was a paper by my Professor Zheng in 2013. Here is some example of complete staghorn stones who underwent mini PCNL in my center. First on the right side, as you can see here, second stage on the left side with a complete clearance, and these are the small staples I prefer to use after removal of the sheet. So this is one of my paper published in 2016 in Journal of Urolithiasis, mini PCNL in anomalous kidney stones. So we can achieve stone-free rate was 89.98%, and stone-free rate improved to 98.3% after retreatment and auxiliary stone SWL. So mini PCNL is safe for management of stones in anomalous kidney with stone-free rate comparable to standard PNL, but with less complications, as I already showed to you. This is a large horseshoe kidney stone, as you can see here, with the multiple stone in different calyx, one stone in the calyx, lower calyx, and all. So we had to make a 4 tracts, in order to achieve complete stone clearance. So in our regular practice, we do not keep nephrostomy tube in our regular practice unless there is a pyenephrosis or patient may need immediate second look. However, we keep double J stent in 90% of the cases, and 10% of the cases we perform total tubeless procedure. So PCNL, whether it's a PCNL or mini PCNL, patient with the several spinal abnormalities is always a challenge. So, however, if we have a good expertise, we can also perform in these cases. This is one case who underwent mini PCNL, and most of our cases are under spinal anesthesia unless the patient is children. So otherwise, we perform, even staghorn stones, we perform under spinal anesthesia. This is another case which is very difficult to keep in position. It almost took us 1 hour to keep in her best position. This is a case of bilateral renal stone who underwent single stage bilateral mini PCNL with the complete clearance. This is another case, a very young chap, as you can see here, who had a ileal conduct, spine fixator, and who had a PUJ stone. This case was performed in Kuwait during my visit, and this patient was with the nephrostomy tube, and we made the antegrade pyelography, then made another tract with the complete removal of stone without any difficulty. So even staghorn can be easily performed in mini PCNL, even in the solitary kidneys. It's always challenge. People select the safest treatment for the solitary kidneys. However, in a large multiple stones, RIRS may be very difficult, and PCNL may be a high complication. But if you go with the mini PCNL technique, the complication rate is much less. This is a case of 45 years who had a left nephrectomy and had a large stone who underwent mini PCNL technique with the multiple tracts, as you can see here. And next day we perform CT scan showing the complete clearance of the stone. There is no residual stone after the procedure. So that is one of the beauty of mini PCNL technique. And this is another one case of young female who had a non-functioning kidney due to upper ureteric stone and solitary kidney with the multiple stones, as you can see here. So we perform mini PCNL with the multiple tracts. So this patient underwent parallelithotomy some 10 years back, as you can see here. Our punctures were more lateral, 4 tracts and 1 more tract from the lower calyx, and complete clearance on table. And it's really a difficult and challenging case. So mini PCNL can be employed on these difficult cases, which is much more safer as compared to conventional PCNL. Even for the calyceal stone, as you can see here, each one stone is about 10 to 15 millimeter. There were around 8 bunch of stone in different calyx who underwent mini PCNL technique with multiple tracts with the complete tracts. So as I already mentioned that if you go with the micro or mini, ultra mini PCNL less than 15 French, you need to have good setup like lasers and all. But If you increase this 15 FR to the 16 or 18 frames, then we can go with the mini PCNL with the minimum use of instruments. And those are the basic instruments, and you don't need all hi-fi setups. And when we go with the mini PCNL, the overall complication rate is 8. And 8% out of that, 7% fall in clavin window 1 and 2. So what is the beauty in mini PCNL? This is a case entering from lower calyx who had a minimal hydronephrosis. As you can see here, you can inspect different calyceal system through one single tract. You can see that's a middle calyx advancing from lower calyx to the middle calyx. This is the case after complete removal of the stone, and we do not leave any stone particles after the completion of the stone. So in mini PCNL, one of the most beauty is on table, you can decide more than 90% of the stone clearance. As you can see here, this instrument was advanced to the upper part of ureter from the lower calyx. Not only that, you can also advance in upper part of the upper pole, and you can check for the residual stone. This is the beauty of mini PCNL. When we go with the mini PCNL technique, it minimizes multiple tracks, which gives a high maneuverability. Well, I conclude my talk that mini PCNL represents a valuable modality treatment for renal stones, capable of offering good outcomes with lower complication rates, even in difficult situations, compared to the standard technique, and higher cost effectiveness compared to the retrograde intrarenal surgery. So that was the end of my presentation, and I have my own setup, Khadgy Institute of Endourology, and this is my team. And I have 2 theaters, one for Rudra Theatre for right kidney PCNL and left kidney for Lasmi Theatre. If anyone is interested to visit, you are most welcome, and they can directly write to me in, and I have a website of kienepal.com, and you can write directly to me, Dr. Sanjay Khadgy @gmail.com. So thank you very much.
Thank you, Dr. Khadgy. Presentation of now, if any discussion, Dr. Khalid, تفضل.
Thank you, Dr. Sanjay. We are happy to have you with us. I'm Dr. Kohlani. Actually, many questions we want to ask you, but I don't. I'm afraid that we will not have enough time to discuss with you all points we want to discuss. My point, which I want to ask you about, are you encouraged to do multi-puncture PCNL in a single or solitary kidney, especially in circumstances that you don't have backup embolization or for any treatment of any complications? What is your opinion? Do you advise to go? Because usually here we are afraid to approach such kidneys with PCNL, even classic or single tract, because of absence of technique for angioembolization in our country. What is your advice for this point?
And that's a very interesting question. To perform multiple tracts in solitary kidney, one needs to have a good expertise. If you are in learning stage, better to go with the one tract, and maybe you can come back after a few days for the next tract. That's my recommendation. In my regular practice, even for a single tract, we do multiple tracts in many cases. That's our regular practice.
Other question, Dr. Khalid. أخذت لها.
Thank you, Dr. Sanjay, for this
Thank you.
nice presentation. My question, you told us about mini PCNL. What's about tubeless? You are doing tube, I mean nephrostomy, after finishing of your procedure, or only tubeless PCNL with double G stent?
Now, in my regular practice,
Thank you.
we do not keep nephrostomy tube unless the patient have a pyonephrosis. We do not keep nephrostomy. However, in 90% of the cases, we keep double J stent. And 10% of my cases, they are total tubeless.
Thank you. Last question. About what the role of bilateral PCNL in pediatrics? What's your opinion?
It depends upon the clinical situation.
In the same session. No, sorry, in the same session.
It depends upon the clinical condition of the patient, how that pediatric patient is doing. How is he in the clinically? If bilateral obstruction, yes, one can do on one side, and another side you can do ultrasound guided PCN, right? If patient is clinically asymptomatic, it's not a big stone, then probably one can go with the bilateral mini PCNL.
Thank you very much, Dr. Khadgy.